In this part of the breathing blueprint, we'll discuss special populations, more specifically, COPD patients, bariatric patients, and special considerations related to laparoscopic surgery. In discussing these populations, we'll discuss three main points: prolonged expiratory time, increased peak pressure, and titrating to baseline oxygen and CO2 levels. When mechanically ventilating the COPD patient, we must increase expiratory time to prevent air trapping. By increasing expiratory time, we will prevent many complications, increase compliance, and improve patient comfort. Often, this simple adjustment from the baseline 1:2 ratio on the ventilator to a 1:3 ratio will prevent any issues from arising in this population. Finally, it's best to provide a tailored anesthetic to these patients and understand the patient's baseline oxygen and CO2 levels. Higher FiO2 levels can often be harmful to this population, so during the maintenance phase, it's best to keep FiO2 levels as low as possible unless otherwise contraindicated. Here, you can see me making a couple adjustments, including the respiratory rate located here and the IDE ratio located here. The laparoscopic surgical environment presents unique challenges to mechanically ventilating a patient. In this environment, we're faced with two main challenges: intra-abdominal pressure and positioning. To visualize the surgical field, the surgeons will insufflate the abdomen, and depending on the procedure, the surgeon may request steep Trendelenburg positioning to offset any abdominal contents from the surgical site. These factors restrict movement of the diaphragm, thereby reducing compliance. Here, we can see that exact situation simulated. This patient is being ventilated with a volume control mode and currently has peak pressures in the high 40s. This patient's being ventilated with a volume control mode, and as we've reviewed in previous videos, we're controlling the volume and not the pressure. Let's titrate this to pressure control mode, where we can control the pressure and not the volume. Now that we've titrated to pressure control ventilation, we can see that our peak pressures have decreased from 46 into the mid-20s. We have a set inspired pressure of 20, respiratory rate of 10, IDE ratio of 1:2, and we're achieving volumes of 271. Now, our volumes are in the 270s, which is very similar to where our volumes were on the volume control ventilation. However, our pressures are much better at 25. But minute ventilation of 2.7 is still very low, so we'll increase our inspiratory pressures to achieve higher volumes. Obesity is a common medical condition in the United States that requires a unique anesthetic approach. Truncal obesity specifically will decrease functional residual capacity and increase difficulty in ventilating this population. Several simple alterations can be made in your anesthetic plan, which will reduce the incidences of complications with this population. Ramping the patient will not only align your axes for intubation, but it will also displace weight from the chest and decrease the amount of reduction of functional residual capacity. Also, it's imperative to perform meticulous pre-oxygenation by observing the end-tidal O2 level on the bottom right hand of the screen. These seemingly small alterations to your anesthetic plan will make large differences in your care for this population.